I don't know, can you see my screen now?
Yes, perfect.
Yes,
okay.
Perfect.
All right. So I practice in Larissa. To give you an idea where Larissa is located, it's in the center of the Greek mainland, in the heart of the Greek mainland. It's an academic town of approximately 250,000 people, approximately 200 miles north of Athens. And it's most probably the busiest epilepsy surgery center in the country. Larissa is known for two things besides the university, of course. It's the place that Hippocrates lived and practiced in Greece, and actually he was buried in the outskirts of the modern city. And the other known historical landmark of the city is the ancient theater, which was built during the early Hellenistic era and is well preserved, is still functional, and is in the heart of the city. It's really worthwhile to visit if somebody wants to come. So these are my, let me see how I can advance that. These are my financial disclosures. I don't think that will affect in any way my case presentation today. I'm not going to discuss any products of these companies anyway. And I chose to discuss a case of temporal epilepsy, and the reason is apparent for choosing that. As you well know, medically intractable cases represent approximately 5 to 10% of all epilepsy cases, and the vast majority of them, around 70–80% of them, have temporal origin. So that's what I decided to do and discuss today. This is a 29-year-old lady, excuse me for a minute, 29-year-old lady, right-handed, who was referred by her epileptologist to our center. She was referred for absent seizures, the frequency approximately 1 to 2 episodes per week, with some kind of worsening during the last 1–2 years. The seizure activity started when the patient was 9 years old. And as you see, the generalizations with tonico-clonic seizures were quite rare. Approximately, they were saying that she had approximately 1 episode per year. She had, in the vast majority of these events, some kind of preceding oral automatisms, some lip smacking and things like that. And auras were quite rare, with some kind of funny feeling in the abdominal area. She was characteristically saying that she felt something like butterflies flying in her belly just before the seizure activity. In regard to her past medical history, as you can see, it was unremarkable. Her family history was unremarkable for epilepsy too. She was a full-term baby, normal delivery, no problems during the delivery, no history of febrile seizures, and she had experiencing no learning difficulties while in school. When she was referred to us, she was neurologically intact. Her speech was somewhat hesitant, I would say. I mean, she was saying that I have no problems, but she was describing herself as laconic, and she was very, very, how can I phrase that? I mean, she was saying just really short sentences for some reason. And she was not a heavy smoker. You can see approximately half pack per day. She was on 3 medications. You can see her medications when she was arrived, although she had tried over the years several different schemes and combinations of anti-epileptic drugs. She had been evaluated by multiple epileptologists, and she had numerous interictal EEGs, multiple brain MRIs, which apparently all of them were normal during all these years of following and going from a physician to physician. She had undergone an extensive workup for ruling out encephalitis or other autoimmune causes for her epilepsy, and everything was normal in that aspect. So she was referred to us, and we decided to record her in the EMU, and as you may see, her interictal EEG showed no abnormalities at all, and her video EEG recordings with no medications, we had stopped her medications for a week just before the recording, showed that there was some kind of theta wave activity over the left middle temporal gyrus. And during her seizures, she was turning her head to the left, movements of the right arm, and the characteristic typical oral automatisms that she had in the vast majority of her seizure episodes. And there was some clustering of her spikes on the EEG, on the ictal EEG, over the middle temporal gyrus on the left side. So we decided to just repeat a brain MRI, and here comes my first comment, because most of the time we see MRIs that are theoretically normal, but if we just start asking questions about what was the protocol that they performed the MRI, what was the information that the radiologist had, was a special neuroradiologist reading that MRI, I think that we do have all this, we do have a really wide variation in that aspect. So we see normal cases without being properly performed MRIs. And I think that we need to make a point, and I don't think that somebody can overemphasize the importance of having a standard epilepsy protocol, which has all these sequences. And I have to thank my neuroradiologist, Dr. Kapsalaki, for doing that for me. And also, apparently the protocol varies from age group to age group. Other kind of pathologists are responsible for drug-resistant epilepsy in patients older, less than 2 years old. Different protocol for patients from 2 to 50 years, and different is the pathology for patients over 50 years old, apparently. So having said that, that was the MRI that we obtained, and you can see that there is some kind of abnormality on the left side. Middle temporal gyrus, I think, is compatible with your electroencephalographic ictal findings. If I go too fast, just let me know, I can stop, but I think that you can appreciate the pathology that you see there. And while we are seeing at the MRI images, I have to say that it's almost mandatory to have some kind of communication with a neuroradiologist reading that special MRI. In other words, I think that the neuroradiologist needs to have all the information, electroencephalographic or information regarding the semiology. I'm saying all that because I know that in the States, it's quite routine to have all these epilepsy rounds, the epilepsy surgery rounds, on a weekly basis or on a bi-weekly basis, but this is not apparently the case in many European countries, and particularly in places that somebody is trying to establish an epilepsy surgery program and has difficulties in communicating with these people. We also performed a task-generated fMRI on this patient. She was right-handed. We assumed that had some right-sided dominance. And you can see that in parroting and verb generation. And there was, interestingly, bilateral speech activation on the MRI that we performed. We did not perform resting state MRI. And this is the algorithm that we use in these cases. So we had some kind of agreement, concordance between her video EEG recordings and the MRI findings on this patient. So we thought that the patient would be a really good candidate for surgical intervention and resection of the epileptogenic area, zone, if you prefer. But we had some concerns if the zone was, the epileptogenic zone was exactly the same with the anatomical lesion. And also we had some concerns with the accuracy of the obtained preoperatively fMRI. You can see the neuropsychological examination and evaluation that the patient had approximately a month or 2 months before her procedure. And as you may see, there was, when she was evaluated by a psychiatrist, had some kind of depression which was not detected so far, and she was on no medication before the event. But nobody had evaluated her before that evaluation that she underwent preoperatively. So, any thoughts for what kind of surgical intervention? Are there any ideas? Does somebody want to say something, or do you want to go ahead and proceed with what we did?
Just first to mention that for people on the audience who would like to ask or suggest things, they could use the chat so that we could go ahead with their ideas and proposals too.
So Costas, I do have a question. How was the memory for this patient? The results related to the memory, especially the verbal memory. I assume she's right-handed, correct?
She's right-handed.
Yeah,
That's
and
correct.
the memory?
Her memory was not affected.
Okay.
And she was working, she was a fully functional person. She was working actually in an administrative job in the Greek army.
I see. Okay. And based on the MRI, what was your suspicious for the lesion?
We discussed it with the neuroradiologist. She thought that this was some kind of migrational disorder, maybe cortical dysplasia. That's what she told us, but you know, she couldn't rule out any kind of gliosis. So we had that dilemma. And we discussed with the patient about the possibility of, we suggest here that she needs to have a resective procedure done. And we suggest her to do that awake, through an awake procedure. And she became ballistic. She freaked out. She didn't want to hear about that. Actually, she left my office when we were discussing that. And she was like, no, I don't want to discuss that anymore. I'm not going to do that. And I'll explain to you why I bring this issue up, because we decided that we wanted some more information. And we wanted to.
Costas, may I just ask about the mesial structures on MRI? Were they considered?
Everything looked symmetrical. And we don't routinely perform volumetric cases, but eyeballing both sides looked quite symmetrical with no enlargement of the temporal horns on any side, no evidence of gliosis, no changes in on the flare images, on the proton density sequences. I couldn't detect something there.
Thank you.
So, as I said, we suggested her to just go ahead with an awake craniotomy, and she didn't want that. So we decided to just proceed. We convinced her to proceed with a two-stage procedure and do some kind of implantation of depth and strip electrodes. Actually, we implanted grids and strips, not depth electrodes on her. And to do some extraoperative stimulation and mapping for defining in a more secure way, more accurate way, the findings of the preoperative fMRI. And she was convinced for that. So what we did, we just performed a standard question mark skin incision, as you may see on the left side. We had adequate exposure there. We implanted, I think that we can discuss that later on about all these tips and all these tips and tricks of implanting electrodes. We implanted a grid and two strips, a 32 contact grid, as you may see, and we covered the whole temporal area. And two strips, we slide them and we cover the temporal pole on that left side. She had no problems with that surgery. These are the post-op x-rays. And we performed the last, we monitored her for 4 days. She had several episodes of seizures, which actually confirmed the findings that we had on the preoperative ictal video EEG. And the last day we performed the stimulation and we had that cortical mapping to avoid any areas for the second procedure for the resection. What we use that protocol that you see here. We usually stimulate at least 48 hours after the implantation to avoid any kind of effect caused by microtrauma and irritation of the cortex by implanting the electrodes. And we routinely perform that language tasks that you may see, at least 4 tasks. If we do have time and if the patient is cooperative, and if they have performed more tests during the task-generated fMRI, we expand that menu to more than 4 tasks. You can see pretty standard stimulation parameters, nothing extreme. We go with intensities from 2 to 4 milliamps. We used to go with higher. Jorge remembers that because we were discussing that in the past. I was using higher amplitude, and we had many events of stimulation seizures, stimulation-induced seizures. So I usually go from 2 to 4 milliamps without anything else. And of course, we record with a neuropsychologist all the cognitive, psychological, or autonomic response that the patient may have. And we came up with, you can see that there was speech arrest when we were stimulating these contacts on the grid that we had implanted. And this is practically the red line is the outline of the planned resection that we had. And we were far away, as you may see, from the speech arrest areas. Of course, when we took her back to the OR, we found that, I would say, routine, typical, and I'll explain what I mean by saying that. Epidural hematoma. Most of the time that we implant subdural electrodes and we take the patient back to remove or resect the underlying pathology, we find some kind of epidural hematoma, which apparently is not significant in the vast majority of cases and doesn't require any kind of surgical intervention. It's a really rare event in our service to take somebody to the OR because of that epidural hematoma. And so this is the map that we had. You can see with the cottonoid the area that we have for resecting, and these are the speech arrests that we had. And this is after the resection. And we performed post-resection electrocorticography, and there was no evidence of epileptiform activity during that recording. So we decided to just go with that. And you can see the post-op MRI. And before going to the histological diagnosis, allow me to just describe to you how she was after the procedure. I saw her, she stayed in the hospital for 4 days after the resection. Everything was okay. She went back home. I saw her again a month after surgery. She was doing great, no seizures. She was still on medications. And I saw her again in 6 months. And she had still no seizures. Everything was fine. Her epileptologist was very happy. But her mother started saying something that we have some problems because she decided to go back to work and she's not doing that well in work. And we found out that, as I mentioned before, she was working for the Greek army and she was a very conservative person before surgery, and she had completely changed after the procedure. She was very aggressive. She was rude at times, and she had some social problems in the work. So there was definitely some kind of change in her behavior, and she was evaluated by a psychiatrist. She had been evaluated just before the procedure by a psychiatrist. So she remained for, I assume, 4 to 6 months after surgery. After that 6-month follow-up in psychiatric evaluation, and she was followed by a psychiatrist, and she was on medications for a while, and gradually she returned back to her preoperative status. In regard to histological diagnosis, the neuroradiologist's suggestion was confirmed. It was indeed a focal cortical dysplasia. There was no evidence of any other pathologies, no low-grade gliomas or anything like that. Her epileptologist decided to keep her on anticonvulsants for 2 years post-operatively and then gradually discontinued everything. And she has remained seizure-free. The last time I saw her was several months ago. She had completed almost 6 years after the procedure and she had remained seizure-free. Now, I would stop here. And as I mentioned, you can see that there was that psychological reaction, how can I phrase that, psychotic event with the aggressive behavior that I mentioned to you before. And that was resolved with medication and psychiatric assistance over a 4 to 6 month period after the procedure. She's still in work. She has returned back to her normality. And interestingly, her speech is more spontaneous than it was just before the procedure. I cannot explain, of course, that. But she was, remember that when I was describing her neuro exam before, she was very laconic. She was saying all her sentences were short. She could elaborate more on her post-operative follow-ups. I assume that I can stop here and discuss any questions, any suggestions. I'm sure that you do have points to make. And then if I have some time, I can just go over the prognostic factors of patients undergoing surgery for cortical dysplasia, for focal cortical dysplasia.
Thank you, Dr. Fontes, for your presentation.
Would you please unshare, Costa, so you can get?
Sure. Let me just, excuse me.
Great presentation, Dr. Compton. Just a quick question. Do you think the aggressive behavior that she displayed immediately after surgery was due to some amygdala dysfunction that was caused intraoperatively just from manipulation?
I don't have a clear answer to that. Let's see if I can answer. Excuse me for a minute. Let me just see if I can. For some reason, I cannot. Now, okay, right?
Yeah, okay, perfect.
Okay, so as I was saying, I don't have a clear answer to that question. I mean, I don't know what was the cause of that.
Costas, I do have a question that was not clear to me on your presentation. How did you define the areas to resect based on the subdural evaluation? Is this was a combination of ictal and interictal? How did you decide the extent of the resection in relation to the lesion? Based on what criteria?
We went with clustering of the ictal spikes. Interictally had no abnormalities. There was nothing that was consistent. I mean, had some theta activity, as I mentioned, but that was not consistent. And that's how we decided to go. And we were expecting to see something more with a post-resection ECOG, but didn't add something. So we remained with the initial resection that we had made. We didn't modify that.
I see. Anybody from the panelists have any other questions or discussion? Go ahead, Chris.
It seemed to me that your frontal exposure was quite large, but I didn't see any electrodes there. So could you comment on this? Was it just a misinterpretation of mine, or was it a large frontal exposure?
No, Chris, you're right. We didn't cover the frontal lobe. And actually, I discussed that with our epileptologist, and he was like, since we know that we do have pathology in the temporal lobe and we do have findings during the ictal events from the temporal lobe, he didn't think that we will get any more information from the frontal lobe. And actually, there was some discussion, and I think that Arthur implied that by asking the question about the mesial structures, about inserting depth electrodes, at least on the left side, and see what's going on in the mesial structures. And he thought that there was no involvement of the mesial structures.
And,
Now,
and her memory was fine.
The memory was fine post-operatively too.
Yeah.
Now, my question to you guys, I know Jorge and Guy make a lot of, they perform a ton of cases with depth electrodes and SEEG. Do you think that this would be a good candidate for ECG and possibly for some kind of lesioning through the depth electrodes?
So yes, I think at least in our center classes, I will probably explore this patient with SEG electrodes, mainly because there are some. I was intrigued by some of your non-invasive data that possibly could suggest that the epileptogenic zone was more involved on the mesial compartment of the temporal lobe. So the absence of interictal activities on your scalp EEG caused my attention that perhaps it was organized a little bit in the deep areas of the temporal lobe, and also the type of semiology that clearly involved perhaps the amygdala or the ventral infra areas that could be also explored with SEG. And also the involvement of the hippocampus, of course, and of course the speech areas, which could be also evaluated by depth electrodes, not so precise as you did with your subdural exploration, but definitely some assessment of the speech. So yes, I think we would probably have performed an SEG evaluation for this patient. But because of the extent of the epileptogenic zone, I don't think this would be that would be a good candidate for, I understand, thermocoagulation or even laser ablation, because I think it's a little bit more in terms of volume larger than the limits of the technology for that. I don't know, Guy, if you want to add anything.
I think it's a really interesting case because there's lots of ways I think different people might approach it. I think that we would also probably at this point in time we would do stereo EEG. We wouldn't be thinking about laser. You know, the imaging, it's interesting that it's a 2B dysplasia. You know, from the imaging, though, it's not absolutely clear what it is ahead of time. And prognostically, the question is how large does the area of resection need to be and how much overlap with function? And I think we would, in our center, we would do SEEG, but we would also very, very strongly consider following that up with an awake craniotomy for resection and do more mapping intraoperatively to make sure the area we wanted to resect would be safe. And then obviously, you know, fortunately in your case, what you found is that you were able to preserve all the basal and mesial structures, which was probably very important in preservation of your neuropsychological function.
Now, may I ask you guys one more question? Do you routinely perform resting state Fmri in these patients, or you just stay with task-generated Fmri?
We stay, at least in our center, we stay with the task-generated fMRIs that we don't perform routinely resting state.
Yeah, I think there was also just before we get fully there, Kostas, also there was one of the questions in the chat. Somebody raised the question about why not just doing a standard temporal lobectomy here? And I think you've got many reasons why you wouldn't, but maybe you could comment on that.
Well, you've already mentioned things about, you've already mentioned some reasons for not doing that. I mean, we would like to perform a modified limited resection so we could preserve her memory and don't sacrifice her mesial structures. And apparently there was no involvement of the mesial structures.
Mm-hmm. I just want to make this clear. What you just said, Kostas. This is not a case, in my view, that we should go for a standard temporal lobectomy a priori because of the dominant side, because of the location of the lesion. I think if maybe a more widespread resection could be indicated, but only guided by more additional invasive data at this point. So I don't think we should have done a standard temporal lobectomy right away with a resection of hippocampus, especially on the dominant side in a highly preserved patient like this.
Now, I see a comment in the chat by Reese about exactly monitoring, implanting depth electrodes in the mesial structures, and I think we've already discussed that. That was my feeling too, that putting a depth electrode there would provide more information to us, but my epileptologist insisted that there was nothing indicating that there is involvement of the mesial structures.
Mm-hmm. Very good. So thank you so much. You have more questions?
No, just want to mention, it's interesting how let's say the straightforward cases are not so straightforward when you start discussing them. I see so many things interesting to discuss in here. For instance, you perform, someone asked about MAG, and maybe you could, and others could comment on MAG if you think it's useful or not. But you mentioned functional MRI, and then you got bilateral speech representation in a right-handed patient. And then there comes the question of, do you value bilateral representation, and you get bilateral representation in a clearly right-handed patient? How do you deal with this information?
Again, I don't have, Arthur, an answer to that question. Personally, I cannot trust the fMRI findings. And that's why we insisted on this patient to have an awake procedure, although the patient didn't want to cooperate on that. And that's why we decided to go with the STIM, the extra-op STIM and mapping. And the other thing is that you mentioned about these straightforward cases. I think that's the good thing about discussing these cases, because there is no straightforward case. That's my feeling. And I think that the same case could be totally different if there was involvement of the mesial structures, for example. And then we would be discussing why we didn't implant depth electrodes and we didn't check the mesial structure.
Yeah, well, at least from my part, I would have a very heavy tendency of disregarding the bilateral findings if they're not very, very, very clear in a right-handed patient, because it's, well, there are some clearly right-handed people with right side dominance, but these are very, very rare. On the other hand, the one thing I think we would not like, I think we probably agree that one thing that we do not like to do in this patient is to resect the mesial structures, right? She has preserved memory. She has normal looking hippocampus. On the other hand, I do agree with Jorge. There are some points that suggest mesial involvement in the ictal phase, like the aura is, an epigastric sensation, the typical automatism, the paresis. So there is suggestion of mesial involvement, but I don't think any one of us would like to, let's say, resect the mesial structures in these patients due to memory concerns. Would any of you consider resection of the mesial structures in such a case, or?
I think we didn't discuss just doing a lesionectomy in this case. What are your thoughts on this? So without implantation of electrodes, just to go for a lesionectomy, because the lesion on the MRI was quite confined. It was on the tip of the temporal lobe, I would say. T1 was not involved, and she was very functional. It was the dominant temporal lobe, so maybe just lesionectomy in this case would be an option. What do you think?
Yeah. So, Chris, I think this is a very important aspect, and I think the lesionectomy will fit well in this case a posteriori, knowing that this was typical cortical dysplasia type 2B, and I think probably a more restricted resection will probably be enough to control her seizures. But before the results of the pathology was, I think it's difficult to define that the lesionectomy itself, it's the pure response for, or the pure localization of the epileptogenic zone. Likely not, as we know in other types of lesions, with the exception of the cortical dysplasia type 2B. So I think you raise a very important discussion, but unfortunately we have the information after we perform the resection. But I agree with your points.
But then let's push the discussion, Jorge. Suppose you have the MRI and sometimes it's quite obvious that it's focal dysplasia 2B. It's sometimes it's just the only diagnosis that can be made there. Sometimes there is a transmountain sign, somewhat so typical that, you know, there's just one diagnosis. If you have an MRI in such a patient with a clear-cut MRI diagnosis of 2B dysplasia, would you go ahead with direct lesion removal, or are you going to be evaluating invasively the patient anyway?
I think it's a consideration that we should have, Artur, because if you have a high suspicion for a cortical dysplasia type 2B and everything, no invasively fits the lesion, I think and we are talking about dominant side. So as you mentioned, the threshold to resect anyway, the major structures will be highly low. So you could make a consideration that probably maybe we could resect or treat this patient with an open resection guided by ECOG, with very specific criteria to guide the ECOG data to guide the resection that will involve the dysplasia and maybe the fast polyspike interictal activity around the lesion. I think that's a discussion that we should have in our group as a possible option for this case. If you really, it's clear that there is a high suspicion for cortical dysplasia type 2B. Of course, this has to be discussed also with the patient. We also like to say that there is maybe a less chance for seizure freedom with this approach, as long as the patient understands. But this is very controversial because we still don't know if invasive monitoring makes any difference in terms of patients' outcomes. But I think this is something we should discuss. We should have discussed in our group and, of course, with the patient.
You mentioned, and Costas mentioned during his presentations, the use of intraoperative electrocorticography. Would you please elaborate a little bit more on how valuable you think this procedure is, and how would you perform it, how you would evaluate it, considering that you have a patient that you already studied in an invasive way, with days of recordings? How do you use and how do you value intraoperative electrocorticography?
So you're asking me?
Both, you and both. Costas. Costas goes first because he presented it first.
Yes.
Okay, I'll tell you this. First of all, you need to have a really good anesthesiologist, very cooperative, which sounds like the definition of oxymoron, to have a cooperative anesthesiologist. But I would say that it's not in more than 20% of our cases that we have modified our resection based on the ECOG. So I think that answers your question, Arthur, about how I value that. I don't think that in the majority of cases adds something. And of course, there is a significant variation on how you perform that, how is the condition of the patient from an anesthesiological standpoint, and how you can appreciate what you see there.
I think Guy has raised his hand. Guy, go ahead.
Yeah, I just think that, so just maybe one final comment, and then we should move on to give Mark plenty of time. But Arthur raised this before, that you have a case like this that on the surface is fairly straightforward. And we've seen that Costas did a subdural grid and then a resection after mapping through the grid, and the patient seizure free. You know, Jorge and I have both said in our centers right now, we would probably do SEEG first, and then at least in our center, we would do very likely an awake craniotomy. We've also heard Reese talk about or suggest subdural grid with depth electrodes. We've heard lesionectomy with or without awake mapping, with or without ECOG. And every one of those approaches in the right hands would be appropriate in this case, as long as you potentially had the right follow-up afterwards and the right discussion with the patient ahead of time, which I think is pretty amazing that you take a relatively straightforward case and there's at least 7 or 8 ways that it could potentially be handled, none of which would be incorrect.
Absolutely right.
Perfect.
Very good. I would like to proceed. Thank you so much, Dr. Fotis. This was a wonderful case, a wonderful discussion. Thank you.
Thank you, Costas.
Thank you, guys. Appreciate it.
Again, I would like to call to the stage Mark Dexter from Sydney, Australia. I believe Mark has 2 great cases, pediatric cases that will present to us. Mark, go ahead.
Thanks, Jorge. Can you see the slides?
Yes, perfectly.
Great. Well, I wanted to thank you, Jorge, and Guy, and also Artur for asking me to present. These webinars have been fantastic, especially for those of us a long way away from Europe and North America, especially during COVID. So I was asked to present some receptive epilepsy surgery cases, and one is recent and one is from a few years back. So these are all fairly, this is a fairly current case. So we were asked to become involved in the treatment of an infant, 57 days old, 4.5 kilos. So the baby was born in Brisbane, which is the state north of New South Wales, where I am in Sydney. The baby was born at 38 weeks gestation by caesarean section because the antenatal head circumference was increased. The antenatal ultrasound was reported as normal and the birth weight was 3.8 kilos with a head circumference of 38.5 centimetres, and the initial well baby check by a paediatrician was unremarkable. So the seizures began when the baby was 2 weeks old, and the baby was hospitalised in the 3rd week of life and basically stayed in hospital until it was referred down to Sydney. The semiology was fairly consistent, reduced responsiveness followed by the baby becoming floppy, eyes turned to the left, tongue and jaw clonus with hypersalivation, and then proceeding to a bilateral tonic seizure with eye blinking. And there were multiple daily seizures occurring in clusters, and some of them quite prolonged. So following the baby's admission, started on Tegretol and pretty quickly increased to up to 20 milligrams per kilo per day. Very quickly after that, additional drugs were added, including vigabatrin, topiramate, levetiracetam, and initially clonazepam, but that was switched over to clobazam. So by week 4 of life, the baby was on 5 regular drugs and was also started on a ketogenic diet. The background workup, his hematology and biochemistry was normal. The SNP array and karyotype were normal. The initial genetic evaluation was also normal, and several EEGs demonstrated long periods of epileptic cycling in the right posterior hemisphere. An MRI scan at 3 weeks old showed a right-sided hemimegalencephaly, and within the limits of imaging in a baby of this age, the left hemisphere looked quite normal. So the brief EEGs performed a week apart again showed asymmetrical slowing and multi-regional epileptiform activity over the right hemisphere, but at times the field extended to the left, but that was felt to be probably propagation. A more prolonged EEG was performed when the baby was 4 weeks old, so the EEG was continuous with, the background EEG was continuous with the central rhythm of 5 to 6 hertz theta. There was some asymmetrical slow waves right-sided, and the sleep architecture was more preserved on the left than the right. Interictal discharges were a combination of sharp waves, sharp and slow waves, and spike waves. Maximal on the right posterior region with the field at times extending over to the left side and frequent runs of discharges and continuous discharges. So over a 2-hour period, they captured 16 separate seizures. So this is with the baby already on 5 drugs and having breakthrough drugs as well. And again, the seizures were at mixed sharp spike waves of the right posterior occipital regions, with the field occasionally going to the left. And the seizure evolution had quite a broad field, but was maximal posteriorly on the right side. The background rhythm was relatively preserved between seizures, and the neurological or epilepsy interpretation was that it was a right central and posterior quadrant, primarily in rectal discharges, and seizures beginning primarily in the right posterior quadrant, but sometimes more broadly. In week 4 of life, a series of bolus drugs were added, and these were changed daily depending on what the baby received the previous day. So these were all in addition to the 5 drugs that the baby was already having. So the baby received additional doses of phenytoin, lacosamide, phenobarbital, and then was having up to 8 midazolam boluses a day. So I think the epileptologists in Brisbane did a really fantastic job of keeping the baby out of status epilepticus and stop the baby from getting intubated. So I think they did a great job of managing a pretty severe epilepsy in such a young baby. So this is the MRI scan that they sent down. So it looks like a right-sided hemimegalencephaly, with the left-sided looking fairly normal, given that this is a relatively unmyelinated brain. And again, you know, the right hemisphere looks large. It looks like the falx is probably deficient anteriorly. And just the other point of note on this, again, a right-sided hemimegalencephaly, but the right hemisphere is bulging over to the left, as is often the case with hemimegalencephaly. But what struck me when I looked at this first one was it looks like there's probably an azygous anterior cerebral artery that then gives off the A2 segments more distally. So we were asked to review the baby by a telehealth conference just before Easter, and at that age the baby weighed 4.5 kilos, was 57 days old, and if you work out the estimated blood volume of a 4.5 kilo baby, we thought that it was probably going to be less than 400 mils. The baby was having multiple daily seizures. The baby was on 5 drugs regularly and having an additional 4 other breakthrough drugs, and had already been started on a ketogenic diet. So clearly, you know, quite a catastrophic epilepsy in a very small baby. So this was the management conference and the discussion that we had. So I guess the questions that would be prominent in everyone's mind, and certainly ours, was when should we plan to do definitive surgery? Should we try and get the baby to 3 months or 6 months? What would be the ideal weight for a hemispheric resection or disconnection, 5 kilos, 7 kilos, or 10 kilos? And if the seizures continued as they were, and the baby needed to be intubated and ventilated, what would be the impact of that on the child's general health and conditioning? And then the other part of the discussion was, what should that definitive surgery be? Should we try just with a posterior quadrant resection or disconnection and wait? Should we go with a disconnection procedure or a hemispherectomy? And as everyone on the panel knows, you know, if you're operating on such a small baby, the unmyelinated brain is extraordinarily fragile and friable, and it bleeds every time you touch it. So I can just pause there if there are any discussions from the audience or from other panel members.
Thank you, Mark. Any questions from the panelists? Or I do have a question, Mark.
Sure.
So I think this it's absolutely a drastic case, a dramatic case, catastrophic epilepsy in a very small child. This is a very difficult decision to take this child for surgery. So I think in general, we have a threshold of 10 kilos to perform this type of, disconnections versus anatomical resection of the hemisphere. But it depends also on the quality of your ICU, the post-op management of those patients. in the anesthesia. So to me, it's a much more complex question. I'm sure you agree that does not only is defined by the surgeon, but also by the whole team, the anesthesia and also the ICU care. So I think it's center specific. How aggressive can you go with this type of situation? And if you have a good team, a good anesthesia, good ICU care, you can be more drastic and perform the surgery in young ages with very low weight. So I just want you to make a comment about that, Mark, about the importance of the peri-op team, the anesthesia, and the ICU for that.
I couldn't agree more, Jorge. I think that's the really critical part of the discussion. So, you know, they have a very good epilepsy unit up in Brisbane, but they don't have a huge experience in babies of this size. So, you know, once this case was presented in our group, I discussed it with our pediatric ICU team and also with the anaesthetist that I work with regularly. And, you know, certainly the feeling was from the team in Brisbane that this epilepsy was getting out of control rapidly. They thought it wouldn't be long before the child was going to end up in a barbiturate coma or a midazolam, you know, infusion permanently in the ICU. And we felt that probably, given the way things were going and the number of drugs that have been tried, we thought that there was probably better to consider moving the baby from Brisbane down to Sydney and considering a resection. And I agree completely. You know, we have to get anesthesia on board, and our anaesthetic team at Westmead is, you know, very competent at dealing with kids of this size. You have to get the hematologists on board because this baby is going to be in a massive transfusion protocol right from the beginning of the case. And again, the post-operative intensive care unit management is absolutely critical.
Yeah. And then
so
Mark,
probably.
Yeah, another question that I have is that you have a paradoxical localization here. So most of the hemimegalencephaly is located in the frontal lobe for this child on the MRI, at least on this. But most of the abnormality, electrophysiological abnormality are located on the posterior quadrant. So you have this connection between the most severe aspect of the lesion versus what we see on the scalp EEG. I just want you to make a comment about that and how this influence your decision of what type of surgery we should perform for this child.
I'll show you a few more MRI pictures. They were the ones that we got sent down, but the MRI scan that we did just on the day prior to surgery in Sydney, it was more posterior than anterior.
I see. Okay. Excellent.
So,
was the baby intubated at this point, Mark, or not yet?
No, they'd managed to keep the baby, you know, breathing spontaneously, even though the baby was having 20 or 30 seizures a day. You know, I think they did a remarkable job. I mean, we've certainly had kids come in, even bigger kids that have spent, you know, 3 or 4 weeks on a ventilator, and usually they're deconditioned. They've got ventilator-acquired pneumonia before we start, and all of that kind of stuff. So I think they did a fantastic job of keeping the baby out of the ICU, just with a combination of bolus drugs.
I'm very concerned about this progressive epileptic encephalopathy. I think if you wait until 10 kilos, which is what's written in the book, I think this baby would get much worse from a neurological point of view. Since activity was preferably in the posterior quadrant, and this MEMAG has a ventricle in the posterior, because I got the feeling that the anterior horn of the ventricle, the frontal horn, was not there. Maybe it was just a cut, but I see the posterior.
I'll show you a couple more pictures.
Yeah. Yeah,
That's our MRI scan on the day prior to surgery.
Yeah, well, but you do have quite a nice ventricular system in the posterior quadrant, and I think you could go ahead basically with the concern of the progressive encephalopathy and do a posterior quadrant disconnection in this kid. The blood loss would be much less than if you go for a resection, and I don't think anyway, at least from what I can see, you have a very good frontal horn. Maybe I could spare this, let's say, second part of the disconnection after I see what happened with the posterior one. I would favor a posterior quadrant disconnection in this baby.
They're all fantastic points, and they're all things that we considered in the discussion. At the end of the day, all of the points that you all have raised were raised in the epilepsy case management conference. You know, people wondered about trying to get the baby's weight up, but, you know, if you force feed these kids, you just put on fat rather than healthy muscle, and that makes the anaesthetist job, you know, more difficult. We all felt that the baby was rapidly developing a progressive epileptic encephalopathy, and despite multiple drugs trials, you know, things were getting worse rather than better. At the end of the day, we felt that it was probably unlikely that a disconnection alone would be satisfactory, because the whole of that hemisphere looked abnormal. And after a fairly agonizing discussion, we thought we would go ahead with a hemispherectomy. So I'll show you how that worked out. So, you know, having done both disconnections and anatomical hemospherectomies in babies with hemimegalencephaly, my preference has been to do anatomical resections. I mean, there's certainly the potential for more blood loss, but in these babies with unmyelinated brains, every time you touch the brain, it bleeds. And you just end up with a really oozy mass, in my experience. So for me, we went ahead to do an anatomical hemospherectomy. When I do this in an infant, I go with a large craniotomy, understanding that that puts the baby at risk of more blood loss. But from my point of view, I want to have early access to the bridging veins and the draining veins, because I think in these situations, if the baby's going to get into trouble with blood loss, it's usually venous rather than arterial. So I tend to do a big craniotomy so that I can see the sagittal and transverse sinuses and the bridging veins that go into that early on. So I do a big craniotomy. I open the dura widely so that I can get, you know, pretty much pan-hemispheric access. And what I found helpful is to, right at the very beginning of the case, clip the middle cerebral artery and the posterior cerebral artery and include them with an aneurysm clip. And that basically makes most of the hemisphere avascular. Sometimes you can go for the anterior cerebral artery as well, but in this case, I was concerned that it looked azygous on the preoperative MRI scan, and I was worried about the potential for injuring the blood supply to the contralateral hemisphere. Similarly, when I studied the MRI scan ahead of time, it looked like the falx was very deficient anteriorly, and I thought that there would be a concern about injuring the opposite hemisphere unless we were really careful. As Arta mentioned, you know, the posterior quadrant looked most abnormal, and that was the bit that I wanted to attack first. So when I do these cases, and I've done a couple of babies of a similar size, I've always clipped off the middle and the posterior cerebral artery. So that's the aneurysm clip on the posterior cerebral artery. That's the tentorium, the tentorial incisura here, and that's the lateral margin of the brainstem. And that basically makes the posterior quadrant completely avascular. And when I've done these hemispheric resections in small kids, really the decision that we have with the anaesthetist at the beginning of the case is that if anyone thinks we should stop, then we stop. So we do it lobe by lobe by lobe. So if we've done the posterior quadrant disconnection or resection, and the anaesthetist says the baby's hypotensive or, you know, we're behind on blood, then we could stop at that point and come back another day. So clip off the arteries first, and as Arta mentioned, I went for the posterior quadrant first. So that's the posterior quadrant resected on block, so straight through the trigone of the lateral ventricle. The falx was present posteriorly, and you've got the tentorium inferiorly, so that is a relatively straightforward disconnection. And again, the problem potentially is always from blood loss from the bridging veins, and that's why, you know, I want to be able to see those veins clearly and coagulate them and divide them with minimal blood loss. And then lobe by lobe, so the second lobe I took out was the temporal lobe. And that's how things looked at the end of the case. So the baby was completely hemodynamically stable throughout. As you can see, the falx is completely deficient anteriorly, so that's the mesial aspect of the healthy frontal lobe, and that was really where the falx begins. And I think, you know, in doing these cases, if the falx is deficient, you have to be extraordinarily careful that you don't damage the good hemisphere. And at the end of the case, we've just got the diencephalon left and the rest is taken out. It just gives you an idea of how deficient the falx is anteriorly. So that's actually the left-sided olfactory tract in the left frontal lobe. There's no falx at all anteriorly and not even a crista galli. And then at the end, this is looking basally, and that's the posterior cerebral artery with the third nerve coming out in front. So there are intraoperative issues, and absolutely blood loss is an issue. So right from the beginning of the case, we are transfusing blood products with the scalp incision. So there's got to be great communication with the surgical anaesthetic and nursing teams. At the end of every lobe, we stop, look around, take a breath, and discuss whether we should do the next lobe. And that depends on whether the baby's getting hypothermic, hemodynamically unstable, where we're at with blood product transfusion. So this baby needed, a lot of blood. So close to 4 times the circulating blood volume, but right throughout the case, the baby was hemodynamically stable, the baby stayed warm, and there was no coagulopathy, and the baby was returned to the pediatric intensive care unit quite stable. And that's kind of what the post-operative MRI scan looks like. I always leave a ventriculostomy in the resection cavity, and I try to reduce the volume of the cavity by putting a lot of gel foam soaked in vancomycin in the subdural space to reduce that volume. And the contralateral hemisphere looks healthy, and the diencephalon looks okay as well. Post-operatively, again, there are always some issues with these sort of cases. So we extubated the baby on post-operative day 3. The baby had to be re-intubated. It was probably a combination of some mild fluid overload. The baby probably had a viral pneumonia because the nasopharyngeal aspirate was positive for rhinovirus. There was probably an element of a ventilator-acquired pneumonia as well, but the baby was extubated finally on post-operative day 5 and went out to the floor. We put out the ventriculostomy on day 14 and sent the baby back to Brisbane on day 23, and the baby's since been discharged home. So very early days, but seizure-free. 2 EEGs that we did post-operatively were both normal, and the baby was sent back on 3 drugs, all of which were being weaned. Clinically, there was a dramatic improvement immediately. The baby was alert, interactive, responded to the parents in a way that they hadn't seen since the baby had been born. And there was suddenly some mild asymmetry of movement. So I'll stop there and pause for discussion if there's any comments from the panelists or anyone else.
May I ask?
Go ahead, Arthur.
No, go ahead. I can.
No. So I just want to, congratulations. I think those were wonderful results, Mark, in a difficult case and very challenged, technically speaking. I just want you to, I would like the clipping of the MCA and also the posterior cerebral artery. And I just want you to be a little bit more specific about that, because I think this is an important technical detail. Is it in which portion of the MCA and which portion of the PCA you clip? For the PCA you get the P4, of course, or how you selected the selection, where to clip the arteries, how you do it more specifically?
So with the middle cerebral artery, I open the Sylvian fissure and I put the clip on just before the bifurcation. So with the idea that we try and preserve the medial lenticular striate arteries that are going to supply the diencephalon. And then with the posterior cerebral artery, again, any bridging veins that are going from the inferior aspect of the temporal lobe, coagulate them and divide them, don't risk avulsing them. And then I normally clip the posterior cerebral artery just as it goes over the tentorium, just at the back of the brainstem.
I see. So at the P4 segment, yeah. Okay, very good, excellent.
I also have some technical questions, Mark. Do you use
Arthur? Can we have, Mark? Can you unshare your? Sorry, go ahead, Arthur. I didn't mean to interrupt.
No. Just wait for the unsharing issue. Okay, perfect. I would like to ask you, Mark, do you use any technique to reduce the subdural space while closing? Do you attach the, I seen the post-op scan, so it's half sub, half epidural space. So do you use any technique? How do you do it?
Yeah. In older kids, I try and suture the convexity dura down to the tentorium, but in little babies, I find that very difficult. So basically, I just plicate the dura so that it shrinks down and it sort of pulls down almost in a vertical plane. I haven't been able to suture it to the tentorium, which is what I do in an older kid or an adult. But I think that helps in reducing the potential for hydrocephalus during the post-operative period. And I normally leave the ventriculostomy in until the CSF looks relatively clear.
And do you take any specific care with the bone? Because if you take sometimes when they're very small, as you know, the bone may come one over the other post-operatively. Do you leave some bone behind, or you just put as it is and wait and see? What do you do?
I put it back in and I just suture it in place, and it tends to heal pretty well. You know, we've also done quite a few resections in kids this age that are not hemispherectomies, and so far I haven't had any issues with bone healing.
But they don't overlap with?
No, normally it will just kind of, you can get it to sit edge to edge.
Thank you.
Very good. Anybody else has any questions? I just want to read Dr. Cosgrove comments. Surgical triumph in Ested Rasmussen used to say, no brain is better than bad brain.
Sometimes it's better to be lucky than good, is what I was told often in Texas as a fellow.
If anybody has any more questions about this case, maybe we can go to the second case, Mark.
Sure.
I see guys with hands up.
Oh,
so.
sorry. So he has a question. Sorry, Guy.
Yeah, it was just a quick comment, just reiterating what you were saying, Jorge, that, you know, we all read the books about, and as you know, as Arthur was saying, you know, we all read the books about certain limits of safety. And Mark, I think you just showed us with this case that, you know, you've got a progressive, terrible situation where sometimes we have to push beyond those limits because of the fact that, you know, the outcome is going to be terrible if you don't. And there's obviously always going to be risk in that. And I agree with everybody that I think that not only did you guys make all the great decisions, but it's an amazing case to show that sometimes you have to get everything in place, do everything perfectly well, have a little bit of luck, and patients do really well when you have to push beyond what we would say are boundaries of safety.
I'll just quickly show this second case. Sorry.
But they are so nice, you don't need to be quick.
Great. So far doing well, and actually has left the Brisbane hospital now. So, you know, just to reiterate some of the technical points, I think, you know, the communication with the anaesthetic, nursing, PICU and hematology teams is absolutely critical. And I think just stopping at each point during the operation where we could potentially close if things are getting out of control is well worth doing in these really little kids. Basically, all of the fluid that baby got was blood product. For me, doing a large craniotomy is important because I've had trouble with bridging veins far more than I have with arteries. I find that devascularizing the hemisphere by occluding the MCA and the PCA is really helpful. The hemimegalencephalies that I've done in babies, the two that have been this age have both had a deficient falx anteriorly, and that's made me really worried that I was potentially going to injure the opposite hemisphere. So I think it's really worth studying that carefully ahead of time. Again, as I mentioned, I did the lobar resection starting posteriorly. It was the most epileptic on the EEG. It's the easiest to devascularize. And if we'd lost a catastrophic amount of blood at that point, we could have stopped. We reevaluate after each lobe is removed, and I reduced the size of the cavity by plicating the dura. This was a paper, many of the people who have been contributing to this webinar have contributed to this paper, and I thought it was a really fantastic collection of cases that came out in Epilepsy in May last year. And really the take-home points were that, you know, it's uncommon, so it should probably be done in centres that do it quite frequently. Usually the epilepsy outcomes are good. They're usually big surgeries rather than small ones. And that the major surgery-related morbidity is not increased with ultra-early epilepsy surgery when it's performed, you know, in centres that have done this relatively frequently. I think the interesting points that came out of that paper was that of the 50 hemispheric surgeries, 10 of them were anatomical hemospherectomies, and these were all kids under the age of 3 months. It wasn't completely specified in the paper, but a third of them required additional surgical procedures. And I just wonder whether this may have been disconnections where the disconnection was incomplete. I know from the paper that Jorge put together when he was at Cleveland that probably almost half of the disconnections in infants are probably incomplete. And I think that just speaks to how difficult it is to disconnect a large hemisphere in a really small baby. And in this paper, as in you know, my patient, there are systemic complications that are significant and they're frequent. So you really need to have your PICU team on board. This is just one other similar case that is now 12 years down the track. So this was a baby that we were asked to see at 48 days when the baby was only 3 kilograms. Talking to the mother, this baby was probably fitting antenatally because the movements that she saw postnatally were what she was feeling antenatally. This baby came to us from a referral centre in far northern New South Wales, and the baby was already ventilated and on a phenobarb infusion when it was sent in. And this, you know, baby was small for its weight. That baby's EEG, it had refractory hemistatus epilepticus, and at least 70% of the recording, the baby was fitting. And that baby kept fitting despite phenobarb, Keppra, Dilantin, Vigabatrin, and midazolam infusion. That baby had a left-sided hemimegalencephaly, and back then we did a PET scan on the baby, and it was hypermetabolic, probably because it was an ictal PET. And that just gives you an idea of the imaging in the PET scan on that baby. So in this one, the frontal lobe was actually more abnormal than the posterior quadrant, and that was very hypermetabolic on the PET scan. And again, you know, a long sort of agonizing discussion with the epileptologist, the pediatric intensive care team, and the anaesthetist. But again, even a slightly smaller baby, so same thing again. A big craniotomy, you can see that the fontanelle is even more open in this baby. But again, I want access to the bridging veins in the interhemispheric fissure. And again, the plan is to end up with just the diencephalon that remains vascularized. And again, in this baby, exactly the same. The falx is deficient anteriorly, which again, you know, we need to be cautious that we don't damage the good hemisphere. And that just kind of shows you in a little bit more detail. So same thing again, there's clips on the middle cerebral artery and the posterior cerebral artery with the deficient falx anteriorly. That baby had a fairly uncomplicated hospital course, so the EVD came out on day 7. We could send it home on day 15, and the discharge weight was just still under 4 kilos. That child's now 12, never developed hydrocephalus, but has a significant global developmental delay, possibly because the encephalopathy was so much worse for, you know, probably a couple of weeks before we got to see the baby. It has a significant developmental delay, and there are still some rare nocturnal seizures. The unusual thing is just how the MRI scan looked at age 7. So you can see that almost the whole of the hemispheric cavity has become obliterated. And because the falx is deficient, so much of the right hemisphere is migrated over to the left. And this is actually the diencephalon here that's rotated up and around. And then on the coronal MRI scan, again, you get this you know, bizarre appearance where almost the entire cranium is filled just by the right hemisphere. And you can see just the diencephalon on the left side, but basically the whole hemispheric cavity has become obliterated. And that was the last case that I had, and I'd be happy to take any questions or open the webinar for discussion.
So Mark, does any of this shift was clinically relevant for this child? She did manifest any neurological decline because of that, or was asymptomatic?
It was entirely asymptomatic. It just, like, with plasticity, the whole hemisphere migrated into the cavity, and the cavity obliterated itself without the child developing hydrocephalus.
I see.
Yeah. I was shocked when I saw that MRI scan. It was not what I'd expected.
It's impressive MRI, yeah. Some of the variations in technique will perform a preservation of the frontal pose and the occipital pose, of course, with the disconnection to avoid this migration. This was described before. I just want to know your thoughts about that. Just to disconnect, but leave in the frontal and the temporal pole to avoid this migration that can be seen drastic in this case, particularly.
I must admit, in larger kids, I've been keen to do disconnection procedures, but just in these really young kids, the brain is so friable. Every time you touch it, it just oozes and bleeds. And I found it very difficult to get hemostasis doing disconnections in the unmyelinated brain, far more than in older kids. So I would often do disconnections in the bigger kids for all of those reasons.
Arthur, you have a question too.
Yeah, amazing images. I've never seen a mesencephalon in the temporal fossa to the other side. They're really amazing. But that's and the other thing that is interesting is because the intracranial cavity on the operated sides used to be larger when there was MEMAG, right? And now it's smaller, and this relates exactly to my previous question: what happened to the extra bone? And in this kid, I inferred that what happened is that it was a kind of resorbed, and then it got smaller and smaller on the operated side. Is that true?
I think it remodels. Arthur, I think the bone actually heals, and just because there's an absent cavity, it becomes smaller. I mean, we often see that, right, with perinatal strokes. Often that hemicranium is significantly smaller than the non-stroke side. And I think it's just a lack of volume in the hemisphere in the growing skull that means that it ends up being smaller.
Yeah, it's interesting because we had some very small babies with very large, proportionally MEMAGs, where the bone, the difference in the intracranial cavities was so big that the bone kind of overlapped with the non-diseased one. But this actually didn't happen in your cases, and actually happened the other way around. It modeled, and it ended very well.
Yeah, I think the bone heals. When we do occasionally a CT, if we're looking to just exclude hydrocephalus, the bone actually looks solid, and it looks like it's vascular as well. It doesn't look like it's resorbing.
Fascinating. Thank you so much.
Dr. Dexter, I noticed that you, in your second case, you had some fiducials on the patient. So assuming you utilize neuronavigation for these cases?
I set it up, but I don't actually use it during the surgery.
And I was just wondering, with such a large surgery with so much brain shift that you're going to be getting, if you were to utilize it, which particular landmarks would you be focusing on? Just kind of finding the MCA bifurcation, locating the fossa at the beginning of the case, or not really utilizing it at all?
Not for the vascular anatomy. With the recent case, I didn't use it at all. It really is there so that if I have to bail out and just do a disconnection or a lobar resection, I know where to make that cut. The middle cerebral artery, you can always find that because it's in the Sylvian fissure. The posterior cerebral artery, you'll always find that as it crosses the incisura. But if you, for whatever reason, say for example, you get quite significant blood loss in elevating the bone flap and opening the dura, and the anaesthetist is saying, look, all you can really do is do a disconnection, then I would use the neuronavigation to plan where I'm going to make the cut through the posterior quadrant.
Thank you.
Mark, I have a question about the decision to perform the anatomical hemospherectomy in this case. This was a little bit different case than the previous one, less drastic, less severe. And of course, the disconnection or the removal caused a motor deficit, permanent motor deficit in this child, who is recovered well, but in the end, they do have final movements in the hand for life. So I would like you to comment about the possibility of performing in partial resections. For example, if you have, like this case, more predominant hemimegalencephaly on the frontal areas, to perform a motor sparing resection of the frontal lobe, preserving the motor cortex, and then see how this patient develop over time. And then if you still having seizures, we'll complete the disconnection or the removal of the entire hemisphere. So in order to preserve motor function, and so staging this procedure in a case that is not as severe as the previous one. So versus performing the complete disconnection in this case. I want you to make comments about if you choose this route for some cases and when you do that.
Sure. Again, we've done that, and we did that late last year in a baby that was even smaller. We just did a frontal resection only, sparing motor. So if the preoperative MR imaging in particular looks like it is much more severe, either frontally or posteriorly, and if that's completely concordant with the EEG, and if the baby is more likely to be controlled with medication, then we would consider doing an incomplete resection or a disconnection, absolutely. The second case was actually sicker. I mean, that baby was in status epilepticus, probably antenatally. And that baby was, encephalopathic from the get-go. The baby really hadn't been, had been basically intubated since the first week of life, and was already quite deconditioned. But in kids that we think we have a better shot at controlling their epilepsy with drugs, and when it's predominantly lobar, both on EEG and structural imaging, then yes, we would do just a limited resection in the hope of sparing motor.
Very good. Okay. Anybody has any more additional questions for both Mark and Costas about the cases presented? Any other panelists? I don't see any points here on the chat. Any questions? Anybody has any more questions? No, I don't believe so. Very, very good. So again, I thank you so much, both Dr. Fountain and Dexter, for such a wonderful presentation, and all the panelists for the discussion. I appreciate it. Thank you so much. And stay tuned for the next webinar.
And I will be opening the room for the post-webinar meeting. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.